Good afternoon, everyone, and welcome to today's edition of Black Health Trust. We are so happy you chose to spend this hour with us. We're going to have another very stimulating conversation that will be guided by our co-moderator, Dr. William Lawson. And without further ado, I'll turn it over to our founder, Dr. Randall Maxey.
Good afternoon, everybody. Happy Sunday. I want to welcome all of our co-moderators. We have a special treat today. Our distinguished guest, who is also a co-moderator, Dr. William Lawson, MD, PhD. I first met him as a professor at Howard University. He's been chair of the board of the National Medical Association, as well as the editor-in-chief of the NMA Journal. He is currently a professor of psychiatry at George Washington University. If I read his whole CV, we'd be here until 1 o'clock tomorrow. So I'm going to simply invite the distinguished Dr. Lawson to speak on, is there bias in the psychiatric diagnosis of our medical practices? Dr. William Lawson.
Thank you, Dr. Maxwell. I'm sharing the screen. Is that how it works?
Yeah. Did you send it to Simon?
I sent it to him.
Okay.
Yeah, but I'll share. Whoops.
You want to put it up, Simon?
Did he get it? I am screen sharing, but do I have my right screen? Okay. What did I just share? Okay. And did not come through. I'll try again. Did his come in okay? Let's see.
No, I didn't get anything yet.
I'm not getting it either. I'll try again, but I can't see okay. Let's try it again. I'll share my screen because it should have come forth. Nothing there. Let me go. Hmm.
You want to give me your email again, Simon?
Yeah, and I'm trying to get into mine and see if I can get it from there. It should have come through. Um, okay, it should be here.
Are you having trouble sharing them, Dr. Lawson?
Yeah, for some reason I can't find on my own system. Oh, here we go. Yep. And then let me go to some, um, hmm.
The screen share is in the bottom of your screen in the middle.
Yeah, I'm trying to find show. For some reason that's not showing. Hosted.
You share your screen first and then
Then go to
like a
show.
movie
Okay.
screen where it says show.
Yeah. Hmm. Yeah. Share screen isn't showing on my for some reason.
Can you advise him, Simon?
This is Dr. Walks. We were able to see your screen earlier, Dr. Lawson. We just couldn't see the presentation.
Yeah, ditto from here too. I'm just trying to find for some reason I can't find the share icon. Um, and it, unfortunately, for some reason, it's not in the middle.
If you're looking primarily at your presentation, it may be covering your Zoom screen in
That
the
is what
share
I,
icon.
yeah,
That's
that
what you're
may be the
doing.
problem. Yep.
See, knowing you, Dr. Lawson, I
There we
know
go.
that the only thing the presentation is going to do is limit you because you can talk about all of this without the presentation.
Can you guys see it now?
No, can't see your screen yet.
Wow. Okay, mine is clear as a bell.
Well, like Dr. Walker said, we can do it without the presentation.
Yeah, but I can, let's see, where is the Google, curious. Oh, okay.
Can you forward this to Simon or me real quick?
Yeah, although I'm trying to find where's the share screen on my system.
And just send it to one of us.
Yeah.
Just forward it.
There
Just
we go. Got it.
email the slides.
Mhm. There you go. And here is my screen. Sharing it. You should be getting it now.
Okay, we got it.
We see it.
Good. Good. You should get the full screen. Okay, I got racial bias and diagnosis and treatment of mental disorders. Can you hear me okay?
Yes.
Mhm. Good. And there I am. If you want to read it, that's your business. Just know that I'm the founder and director of the Institute for Reducing Disparities, among other things, past president of the senior psychiatrist. And I don't have any thing to disclose in terms of any pharmaceutical money at present. I will discuss some off-label use of some medications. And just want to show some books that are still in press that you might want to read if you have some spare moments, although some of the information is dated. And that is a chapter in the disparities in psychiatric care, which talks about some of the issues that bring out, and also the book on cross-cultural psychiatry, which I understand is still in press but very expensive. Recently, Dr. Prim and Dr. Norris collaborated with us to produce what I think is a very excellent book, Mental Health, Racism, and Contemporary Challenges, which is available through the American Psychiatric Association Press and also uh, through Amazon. And then there's, of course, my book, African American Health, my editorials when I was editor-in-chief of the Journal of the National Medical Association, and was, I don't know if I'm pleasantly or unpleasantly surprised to see that some of the editorials that I thought would be dated have actually become very, very relevant at the present time. Now, I just want to again make the point that's been made repeatedly that race is a social cultural concept, very little genetic basis for it, although it's become of interest, especially in terms of some of the recent findings about earlier hominoids that have been integrating with Homo sapiens, that they have importance in terms of the resistance to disease states. But I do want to note that race uh, is an important factor that impacts diagnosis and treatment of psychiatric disorders and may impact substance abuse services. And that because of misdiagnosis and underdiagnosis, we do not have the access to treatment that we should have. And also that there is a tendency to refer people with mental disorders, substance abuse disorders, to non-mental health settings where treatment is often not optimal. This is just an older slide showing that's, I'm trying to get some recent data, but it's the same trend, that is that Caucasians are becoming a smaller percentage of the population and will soon become less than 50%. It's already the case in Montgomery County, Maryland. But it's not so much that there are more African Americans, but that we've kept our birth rate pretty much the same. The important point that Dr. Chapman, slide I borrowed, has made, and I concur, is that there are some key points in our history that has both general health complications, but also mental health and substance abuse. That is, of course, slavery, after slavery, the Black Codes, civil rights era itself, which also had some other complications, what's happened more recently, and today. And the key point that I think many of us are making, and I just listened to a talk when Martin Luther King was despairing that at the close of his life, that even though we have made tremendous gains, that we also had not gained as much as we probably should have, especially in our community. And it is distressing to see that some of the issues that were raised in slavery times, very, very relevant today, and has not improved outcomes very much at all. Now, in the past, a working hypothesis that actually helped to justify slavery was that African Americans were incapable, people with African ancestry were incapable of high functioning and emotional depth. If you accept this idea, then you don't worry about individuals' interpersonal life. You don't worry about how they feel. You don't worry about the consequences. They're pretty much intelligent machines working in the fields to try to support the culture. And what disorders that they were there included such things as drapetomania, which was the running away disease. Anybody who wanted to run away from slavery was considered to be mentally ill. And the more liberal people at that time talked about a phenomenon called negritude. That is that having Black people were different from white people because of the dark skin. And if they could only change their skin color, they'd be just like white people. Again, ignoring the rich cultural as well as personal connection that existed in individuals. This is a timeline. It wasn't until 1773 that there was a mental hospital admitted Blacks, and also Central State Hospital, which I had a relative in, which was one of the first hospitals that would admit African Americans with mental disorders. Interesting to note that these hospitals had unmarked graves showing the value of those with mental disorders. In 1844, the American Psychiatric Association was formed. In 1851, the recognition of that dread disease called drapetomania, running away disease, was publicized. Then hospitals were allowed to segregate hospitals were allowed for African Americans. The famous notorious 1840 census, in which had some weird findings, such as rates of insanity among African Americans in communities which there were no African Americans. 1847, the American Medical Association was formed. 1910, the famous Flexner Report, which resulted in his efforts to improve medical care by getting rid of places that he thought did not provide inferior care. And that included, I think it was six African American schools were closed, but of course Howard and Meharry survived. And oops. Then the famous Friedman and Kaplan book. This is one of the first chapters that dealt with the issue of mental illness. And there are certain topics that were not discussed, including race, racism, Black, Negro, color, prejudice, stereotyping, discrimination, and segregation. We're almost returning to that time because of the restrictions on such things as gun violence, and also getting rid of DEI. So what comes around comes around. My system is. There we go. And here is, of course, Solomon Carter Fuller, who was the first African American psychiatrist. He, of course, was born in Liberia. His family actually came from around Petersburg area and moved to Nigeria, where they thought they could have better opportunities, and he certainly did. Came to Liberia and then came to the United States. Studied with helped lead the work in terms of Alzheimer's lab to identify the on the biological basis for Alzheimer's disease. Oops, did we lose you? What happened there? I'll share again. Not sure what happened there. Oh, here we go. Oh, did I get it back again?
Yep, we can see it.
Okay, good. For some reason, I don't see it well. Well, anyway, we'll move forward.
We can see your screen, but you're not in slideshow mode anymore.
Yeah, and I'm not sure why.
You push the down arrow and you change the slide.
Please settings. I don't see slideshow mode.
If you just, Dr. Lawson, if you just go to your left and click on slide 13, the next slide will come up.
Yeah. Okay. Yeah. The thing is,
there you go.
Yeah, but can you see the full thing?
We can see the slide.
Yeah. Oh, okay. You don't see the stuff on the side and all that stuff. Okay. Anyway, we're going to talk about the issue of mental disorders, and just wanted to note that several studies, I'm not going to discuss in any detail, the National Comorbidity Study, then among others. Basically, these were knock on the door type of direct interview studies, did not find any significant difference in terms of the prevalence of mental disorders. And I will continue that. Then this David Satcher's famous supplemental report on mental disorders. One of the key points is, again, found no substantial difference in prevalence. So we're working on that assumption that when you use standardized tests, when you use more or less objective data, you do not find differences in terms of mental disorders. So here we go. Oops, got it. Okay, now you should be seeing, you should be in slideshow. Is that correct?
Not yet. We see this. We can see your slide, but you're not in slideshow yet.
Huh, okay. Yours truly is in slideshow. Okay. I don't understand why this is. Okay. Mm.
I was just using current mode.
Am I still in slideshow on yours?
No, we're seeing slide number 14, reports.
Right, yeah. Okay, I'm just trying to be able to move it ahead. Yeah,
Press the down arrow.
If
yeah.
you just move your mouse over and click on slide number 15, there you
Yeah,
go.
I
It'll
can't
come
see
up.
that. Unfortunately, I can't see that.
Okay.
Okay, just wanted to note again that Satch's picture is on mine. And just want to know the disparities in diagnosis. And again, not sure why it's not on slideshow. The, hmm. It's still not in slideshow in your mode.
Dr. All this is being recorded. Why don't you just talk without the slides so you can see it?
Yeah. Anyway, we'll continue. I am in slideshow, and I'll just continue from assuming that you can see most of the slides. And what I'm looking at, can you see the slide that says disparities?
Yes.
You're right. Okay, just wanted to note that we have found disparities in terms of diagnosis, treatment, access to care, and it's greater for African Americans than any other group. And there's evidence, at least this is from 2001, that's showing that it is actually increasing. Um, and what is the impact? Why is diagnosis important in terms of mental disorders? Well, recently we've had increasing rates in suicide. It's increasing faster among people of color than any other, especially African American men. There's also been a surge in drug overdose rates, although that has begun to decline. Um, and Dr. Chapman and I have talked about this, and others have noted, well, that it is probably related to issues in terms of access to mental health services. So what does it mean? It means that there are deaths in our community. It's not just from diabetes, not just from hypertension, it's not just from general medical conditions, but there's an underlying factor of mental disorders that's contributing to deaths through suicide, through violence, through joblessness. A major factor in joblessness is that when people are mentally impaired, they lose their jobs. Poverty, people that have chronic mental illness are chronically poor. Homelessness, disproportionate number of homelessness population, maybe more, as much as half, have severe mental disorders. Malnutrition, people who are mentally impaired for whatever reason do not eat healthy diets, and in fact, we eat very unhealthy diets, and it's very difficult to get them to change their diets in a way that is very related. And it's related to the level of next year.
We can see slide number 19 that reads, so
Yeah,
what?
yeah, my system won't budge for some reason. Okay. Uh, Okay. Hmm,
You,
yeah.
you can't click on slide number 20, Dr. Lawson?
For some reason I can't. It won't accept. Yeah. Here we go. Try
Yeah,
it.
there you go.
Okay. Okay. So let's go to 21. Good. It's not reacting.
We can see slide number 21.
Yeah, my problem is my system won't respond. Okay. So we're going to cancel that.
Dr. Lawson, you can give the lecture without the slides. Are you there? Can you hear us, Dr. Lawson? Is he muted, Dr. Walks?
I don't see him as muted. I'm not sure what's going on.
Okay,
Yes,
here we
he's
go. I just got back. Just got back on. Okay, and then I am now going to share again.
Dr. Lawson, you can give us the lecture without the slides if you like.
Sure, and I'm going to move ahead very quickly. Mhm.
Dr. Lawson, if you could just stop screen sharing and just talk to us about
Yeah,
what you've shown so
what I'm gonna
far,
do. I'm literally can't
that
get
would
out of
be great.
screen. Yeah, the problem is I can't get out of screen sharing. Sorry about that.
There we go. You're out now.
Yeah. Let me try this one more
Forget
time.
the slides, Dr. Lawson. Just talk to us. Just talk to us.
Yeah.
Dr. Lawson,
Yep.
just talk to us without the slides.
Okay, okay. Yeah. Anyway, I want to join. Okay, got out of it. And I just wanted to just note that the point that I want to make at this point is that what we're hearing is the consequences of mental disorders in terms of the problems that it has in general healthcare. That is, it's not limited to just mental disorders, it's also impactful for other consequences of care as well. And how that is demonstrated in several ways. I mentioned the problem of malnutrition, appetite, and so forth. But it also has important implications in terms of interpersonal relationships, in terms of education, and in terms of the access to services. We've talked about the difficulty in getting people to eat healthy lifestyles. We also talk about the difficulty of managing taking such things as necessary medication and that's necessary to make sure that you maintain your blood pressure and also help to keep diabetes under control. The uh, limiting factor also, though, is that it seems to be related to diagnosis. And that is, people with severe mental illness, such as schizophrenia, have greater difficulty than some of the others in terms of making decisions. And an underlying factor also is that there's a tendency to overdiagnose schizophrenia, which is a very, very important um, issue in terms of our community. Oops, wrong one. And that is that what we find is that some disorders, such as schizophrenia, seem to is thought to be uh, more common among African Americans. What is the evidence for that? I'd like to show that slide, but I can't, unfortunately. I'll try again.
Dr. Lawson, if you can just talk to us about what you
Yeah,
know without the slide,
can you hear me right now?
we can hear you perfectly.
Beautiful. Um, Great. And also now my slides are moving.
Don't worry
Dr.
about
Lawson, I'm gonna drive over to your house and I'm gonna turn off your slides.
Yeah,
So
can you
so
see them right now? Can you see slides now?
no, just see you,
Okay, then I
man.
won't
That's
worry
all we
about it.
need is just to see
Yeah,
you.
what we found is that the problem in terms of diagnosis is that there's overdiagnosis of schizophrenia among African Americans. The extent to which this overdiagnosis occurs varies from study to study. We found is that we've looked in multiple settings, public settings, in terms of um, correctional settings, in terms of um, hospital settings, and we find an excessive number of African Americans been diagnosed with schizophrenia. And there's been several excellent books noting this. Not only is there an overdiagnosis of schizophrenia, but that schizophrenia itself is often has a different role in African Americans. Dr. Wetzel, who just recently gave an excellent talk locally, uh, noted that among knows that most of the time, what we found is that is that well, African Americans with schizophrenia are much more likely to be perceived of as being violent, which is not the case in terms of the general population. And also, schizophrenia was used to be old white ladies sitting in the quiet, being quiet, began perceived of as very angry young men. And these folks were considered to be extremely dangerous. And so that changed the perspective of how you treat schizophrenia. More was quiet people down, getting them under control, rather than simply trying to get the best treatment possible and making sure they have improved quality of life. And it wasn't just schizophrenia. There was also a vicious cycle in terms of how to deal with anxiety and depression. Um, there's overdiagnosis of schizophrenia, under recognition of depression, under recognition of anxiety disorders, which has led to problems in terms of people wanting to treat themselves, often with controlled substances, street drugs. And that in turn increased the risk for drug-related violence, increased risk of traumatic experiences, and increased risk of precipitating underlying certain kinds of mental disorders, especially the stimulants and some of the hallucinogens. If folks had underlying mental problems, it came worse with these disorders. And one of the other observations that we did in terms of our own work is to demonstrate that mental disorders did in fact occur in non-mental health settings. One of the areas in which we found, and this is a study that we've reported on several times, myself, Dr. Tanya Leem, and others, we went into our primary care setting to find out how often did we find mental disorders. And we found that more than half of the individuals in the primary care settings had various kinds of mental disorders, mostly post-traumatic stress disorder and depression. But also, we found actually a disproportionate number of schizophrenic patients that I'll come to later. This, by the way, is a slide showing Dr. Metzel's book. And I just want to make the point that we don't have right now a consistent genetic marker of blood tests for most psychiatric disorders. There are suggestions using populations that can use these tests, but right now it's not very useful in terms of diagnosing individuals. So that means that there's going to be disparities in healthcare, including misdiagnosis and underdiagnosis, because of people's stereotypes and misconceptions rather than their symptoms. The underdiagnosis of bipolar disorder especially is one that's really a concern. As those audience may know, bipolar disorder, manic depressive illness, is a mood disorder in which folks may switch from moods of extreme excitement, irritability, euphoria to major depression. It's interesting enough, this is a mood disorder that's often is misdiagnosed as a thought disorder, which is schizophrenia. And again, this is very, very common in terms of African Americans. The idea is that somehow we're much less likely to be to have some sort of mood problems and much more likely to have thought disorder. Also, underdiagnosed of post-traumatic stress disorder. It's good evidence that this is one disorder that's probably very common in the African American community. And it's a result of the exposure to trauma that many of us have. And as I said, the problem for underdiagnosis of depression. And as a result, we often don't get the ideal treatment that we should get. Do not get psychotherapy, don't get antidepressants, don't get the new antipsychotics, and less likely to, when we do get medications, especially antipsychotics, folks are often overdosed or get excessive disorders, excessive doses. This is just a slide showing that looking at multiple settings, we're finding overdiagnosis of schizophrenia.
I wonder if I can ask you a question. Can you define for us the major psychiatric diagnosis? What is bipolar?
You mean all of them? Okay. I'm sorry. I apologize to the audience. Yeah, we used one we were talking about that, but basically four of them. Talking about mood disorders, which are the depression and bipolar disorder, where folks have mood swings. Thought disorder, which is schizophrenia, where folks have beliefs of thoughts that are inconsistent with reality. Anxiety disorders include panic disorder, and now had post-traumatic stress disorder as an anxiety disorder. Now we look at it as separate in its own. And again, post-traumatic stress disorder, folks that have a traumatic experience or risk of traumatic experience, and as a result, you can have flashbacks that can be disruptive.
What does bipolar mean? What does bipolar mean?
That means swinging from one mood to the other is the basic idea. Folks can have hypomania or mania, in which they have grandiosity and feelings that they are top of the world. And it can be mild, go on gambling sprees, have 5 million girlfriends, go from place to place, trying to have a good time, all the way to and end up requiring hospitalization because you believe that you, as one patient told me, he was in fact the angel Gabriel and going to save the world. Or they can swing, and sometimes these swings can be very, like in a day, or it can be like months to years, to the major depression, in which they have reduced mood, and in which they feel despondent for days on end, so it's disturbance in terms of sleeping or eating.
So let me ask you one more question before we go to our moderator. Uh, what relationship does the gut and the microbiome have to mental health in terms of things that produce hormones like serotonin, etc.?
Yeah, the underlying principle for many of these disorders is disturbances in terms of the neurotransmitter systems, and which produce in the gut as well as directly in the brain. I actually did a study a while back, in which the patient had, they thought bipolar disorder, but found that he had a tumor in his gut that was producing excessive amounts of catecholamines. So, um, and does that happen normally? Well, I won't say normally. Does that happen consistently in terms of mood disorders? We don't know at this point. All we do know is that sometimes some of the same kinds of neurotransmitters that gut can sometimes produce can lead to what appears to be mental disorders. Well,
Okay.
that accounts for most mental disorders. There's no evidence for that thus far. People with mental disorders, however, do have GI problems and issues, and there's an interesting relationship between autism and the risk for various kinds of GI disorders.
Dr. David Stevens, do you have any comments or questions?
Yeah, I do have a question. My question is, how can a person who has any of the diagnoses or any mental health diagnosis at all, how can that person protect themselves against discrimination in treatment? And what are the best ways to advocate when uh, you think you may be subject to discrimination in your treatment?
The good news is that we now have some organizations that you can work with. You can that are peer-supported organizations, including the Depression Bipolar Support Alliance, National Alliance for the Mentally Ill. In addition, we have some professional organizations, Black Psychiatrists of America, Psychiatry Section of the National Medical Association. These groups have individuals, if you contact them nationally, have individuals who can go and become your advocate in various kinds of issues. They've been very effective in terms of such things as improving access to services. Organizations such as the National Medical Association, as many of you know, was key in terms of making sure that Medicare and Medicaid especially, was made available. And Medicaid is a very important component to providing not only treating physical problems, but also mental health services, and in some states, especially with expanded Medicaid, access to psychotropic medications and access to substance abuse programs. Before the Affordable Care Act and others, substance abuse was often treated either by support organizations alone, or the correctional system. Now we have some genuine options for people with support substance abuse problems. We now have more evidence now that some of the medications that's been developed, such as buprenorphine and others, can change the trajectory in terms of whether or not people can live normal lives, even after years of addiction. Similarly, we've found the same thing that naltrexone and others been very effective in terms of treating alcohol use. So the good news is that because of the demands from our community and because of these advocacy organizations, that we're now focusing on getting treatment for the individuals rather than simply getting um, punishment, and also dealing with the stereotypes that exist in our own community, in which we do not get the kind of support that we should have.
Dr. Walks?
Uh, Thank you, Dr. Maxey. Thank you, Dr. Lawson. I know how much is in that big brain of yours, and sometimes the slides can just slow you down. So I want to take you in maybe a slightly different direction. When I think about diagnoses of African Americans and misdiagnoses, I go to something I saw a couple of weeks ago where a young man was clearly manic and was acting out, and law enforcement diagnosed him as a violent problem and someone who wouldn't follow directions and wouldn't do what they said. And I think one of the challenges we have is that there's still training in people who are supposed to diagnose folks that look like us, and they're not doing a good job of diagnosing it because of some of the things you talked about earlier, some of the racial things, some of the stereotypes that, like Dr. Maxey just mentioned. And I guess my question is, how do we get the folks who we sometimes come into contact with, who want to treat us as one way, when what they should be doing is treating us as someone who has some sort of a health condition and needs help? Because I think that's part of the misdiagnosis. Is that fair to say?
Absolutely. I was involved in all of this because I was actually trying to get schizophrenia listed as a neurological disorder. And the reason was that you're saying if someone goes out and punches somebody or even stabs them because they have a seizure disorder, it's a whole different trajectory than if that person is being looked at as if they have schizophrenia or others. So part of it is also to work with individuals across disciplines and across settings to recognize that mental disorders is not some sort of separate alternative parallel universe, but are very real conditions that we now often, not always, but often have treatments for. The, I was recently involved in a program in which we were working with folks in Nigeria to recognize that autism was not demon possession. It was very effective when we helped family members recognize that the person, he's not a demon inside of him. He has a neurological developmental problem that can be managed. Similarly, even here today, we have people who are saying this person is come a whack case or whatever. And I still watch movies that come out and say the person has some sort of incurable psychosis in which they're doomed to be out of touch with reality forever. It's not the case at all. Many times, especially some of our newer treatments, we can help people, but they got to be in a position to be helped. And that is if a person is on the street or in a correctional system that has limited resources, very difficult to give them the help they need. So we need to work with our politicians, with our Congress people, with our providers. And I'm sorry I wasn't able to show that slide, but again, I just want to note half the people we found at Howard, and also it was replicated in Columbia, half the people in the primary care clinics had problems such as unrecognized post-traumatic stress disorder or major depression. And we found that a significant number, almost 10%, had mood disorders, bipolar disorder. Again, these are in well-regarded academic centers, in which I think the providers should be aware of, but because of time commitments, because of their own background, because of their own concerns, they sometimes miss these diagnoses.
What some of the things you're reminding me of is that some of the things that we think are purely psychiatric are also physiologic in nature, and we need to be more aware of them. I recently reread a book that I read almost 50 years ago called They Came Before the Mayflower. And this book tended to explain a lot of the things that are in our medical and psychiatric histories. I invite people to review that book by Lerone Bennett, which was written many years ago, but is very relevant. But are there any questions that people have uh, in our chat, Dr. Neighbor Stephen or Dr. Walks?
No, I don't see any questions.
Let me just say that came for a Mayflower is still pretty rare and recent for me because I remember reading a few years ago.
Dr. Gibson has raised his hand.
Dr. Gibson? Is he unmuted?
I am now. You mentioned earlier that it was difficult to actually look at treatment for patients that might be suffering from implicit bias of all kinds, especially of the racial variety. What I'm curious to know is how is the interview process addressed by practitioners such as yourself and Dr. Walks in making sure that we get the basic PMI, family medical history, and those sorts of very, very important things when we're addressing the psychiatric challenges of these patients. How's that addressed? How's that approached, I should say?
When I was studying, one of the things we found that contributed to misdiagnosis is that, interestingly enough, we find when we're working with African American patients, even though African Americans tend to bring family members into the dialogue, no one talks to them. When we look at our Caucasian patients, they do go out and get additional information. They do talk to family members. They do talk to colleagues. So that's the part of recognizing that the family has a role, and talking to family members can be very important in terms of clarifying some of the difficulties that may exist. We found in the West Coast, we found many times folks that spoke English as a second language, they had to have, they used not only family members, they used the kids to try to get the clarity of what was going on. And that had its own issues because then you had to teach the child how to recognize, to learn something about mental disorders. So part of it is to try to get as comprehensive information as you can, even though your time may be limited for a variety of reasons. When I'm using more standard instruments that can often get a lot of information just by a few questions, I think AI can play a very important role if properly trained to be able to address these issues. I think Dr. Waltz also has some thoughts about this.
So if I hear you, then maybe there's a window of opportunity for students to get involved. They often have practicums that they get credit for literally engaging with patients, especially at-risk patients, unhoused patients and such. Maybe we could approach it through students and what are called community health workers, the promotoras.
Yeah, DC has, of course, has a number of different programs that can actually pay health workers, but some states do not, and that is the problem. I think Affordable Care Act was, I think, played a very, very useful role in terms of that. If you're obviously in an academic setting, you can do quite a bit. And a part of it, in terms of working with community health workers, of course, is the stigma issue, helping people get rid of the fear. That's what's going on. And again, just like we're doing in terms of more and more in substance abuse, bringing in folks with lived experiences who can play a very important role in terms of stepping in and helping provide some perspective, and also let the individual who is having problems know that they have an advocate that may have had some of the same, went through some of the same kind of stuff that they went through.
Thanks, sir.
Dr. Lawson, I thank you for your presentation today. We're going to have final comments, concluding comments I would like to say. Would you like to start with you and then Dr. Walks, Dr. Neighbor?
Yeah, I just want to emphasize part of what I wanted to do. This is Minority Mental Health Month. I want to emphasize that we like to look at mental disorders as something that's somewhere in another parallel universe. We will see folks who have mental problems in all kinds of settings, including our primary care settings. I saw a guy standing in the middle of the road the other day when I was driving down, and among family members. Almost all of us, if you go back far enough, is going to find a family member who has a severe mental disorder. Important thing is to recognize that these uh, mental disorders, substance abuse problems, we now have treatments. They're not always effective, like anything else that's not always effective. They now doesn't always work forever, like everything else that we have doesn't work forever. But starting from that place, where I think we can make substantial gains in the long run in terms of helping individuals.
Well, thank you so much, Dr. Lawson. Appreciate you. Dr. Walks.
Thank you again, Dr. Lawson. Always a sad joy to listen to you because you talk to us so effectively about things that need to get better. So I appreciate you always bringing such a great level of scholarship to the conversation. My comment is that this issue of how we are diagnosed and how we are approached is really a huge opportunity for us to get beyond the emergency room, and I mean the psychiatric emergency room. Folks are often identified when they're not comfortable, where they're uncomfortable with what they're seeing, what they're hearing, what they're feeling, and so that tends to get treated. Somebody is agitated and anxious, they tend to get something to calm them down. Somebody is doing something that puts them at risk, and that behavior is focused on. And I think that there's an opportunity for us to ask for more from the healthcare community, to ask for some therapy, for some counseling, to ask for some, not just medicine to deal with the manic symptoms in someone who's bipolar, but some mood stabilization medications to help keep them in a range where they can function comfortably. So I think that this topic of conversation is really an opportunity for us to ask for more, for more than just an emergency calm it down approach to mental health in our community.
Thank you, Dr. Walks. Dr. Neighbor Stevens.
I want to tag on to what Dr. Walks was addressing, but from the other end of it, which is it can be very scary and very intimidating as a family member or a loved one of someone who is having not necessarily an emergency crisis, but who is clearly not well in terms of their mental health. And it is extremely difficult. And we need to be upfront and acknowledge this. It is extremely difficult to access good mental health care in this country. And what I hope we can help supply to our audience are tips on how to know that there's a problem, and then how can we help the problem besides going to the emergency room? Because I guarantee you, if you take a list of psychiatrists in your community and you start calling those offices, you're lucky if you can get an appointment in 6 months. And so that is a very disheartening experience when you're worried about your loved one. So we have only scratched the surface on this. And I do hope that we can come back and talk about what I'm talking about. What do you do when you can't get an appointment? Whether it's a private practitioner, a clinic, or even telehealth, which has some issues. But this is a crisis point in our healthcare delivery system, has been for some time, and we need to call it out. Not that others haven't before, but we need to make it a priority, just like we worry about high blood pressure.
I think that's a very relevant point, Dr. Neighbor-Stevens. One of the things I'd like to do soon is discuss some of the relevance of what's happening with the new bill that just passed through the Senate and the Congress and how it's going to affect healthcare. I know a lot of our people are going to be extremely impacted by what Congress has just done, what the president signed into law. But that's another Sunday. Everybody have a great, great day. Thank you, Dr. Lawson. Thank you very much.
Thank you.
And have a great day. Simon, thank you for your help. Thanks, Dr. Lawson. Thanks, Dr. Walks and Dr. Neighbor-Stevens.
Good day,
Bye.
everyone.
Bye-bye.